Good day, everybody. Greetings from Singapore and the Singapore Society of Ophthalmic Plastic Reconstructive Surgery. I'd like to compliment Dr. Farzad and the entire ITEDS team for putting together this beautiful course and inviting me to share my perspective on quality of life in thyroid eye disease. So what is quality of life? The standard of health and comfort of the patient and the happiness experienced by an individual as in a patient afflicted with thyroid eye disease or a group. And in this situation, we're talking about the family, the society, and the nation at large. A large proportion of what I'm going to talk about is what we published in a major review on the quality of life in thyroid eye disease published by various experts from around the world. Not just greetings, but acknowledgements from the numerous people from whom I've learned a lot about thyroid eye disease from. When you look at quality of life, what we're doing is measuring the ability or the disability of the patient affected by the disease. It also helps us understand the disease and its morbidity. And like I mentioned earlier about the individual being affected, the family and the community being affected, and the healthcare resources being distributed and consumed in the management of these patients. It is oftentimes used to assess indications and outcomes of both medical and surgical interventions. And not to forget that a lot of these patients have also residual disease, which have to be looked at too also. We're familiar with the natural history of disease. We're often alluded to the Rundle curve, but keeping in mind that not all patients follow this curve strictly, and it's not usually a single Rundle's curve. And a lot of patients have reactivation over time as time goes by. We tend to think that it's the active inflammatory phase of the disease where people are affected, the quality of life is affected, but you have to remember that not all active inflammatory patients have the congestion, the erythema, injection, so on and so forth. You can have the silent active disease where we oftentimes underdiagnose and undermanage these patients. Again, inactive burnt out phase disease patients also have significant morbidity. And we have to get rid of the mindset this is a short-term active disease and hence focused attention during that period. But remember, these patients have lifelong morbidity, and it's akin to a chronic disease. There are several myths and misconceptions. It's only the active inflammatory phase of the disease where the quality of life is affected. It is oftentimes thought that it's only the severe disease and sight-threatening disease where the quality of life is affected. And only if you're a leading, active, professional, social, physical life, the quality of life is affected. And we used to think in the past that as long as you save the vision of these patients, you have made a big impact in their quality of life. But remember, unlike proptosis, which was initially thought to be causing the significant disfiguration and disability to the patients, the double vision, which I think is more important to be addressed, especially when it's induced diplopia. Here are examples of patients where seemingly an innocuous kind of disease, where the patient's quality of life is moderately affected, whereas a patient like this who's got obvious severe proptosis with strabismus and is able to suppress the second vision is really not really affected as well. So why is this important? Quality of life assessment is important in determining the threshold for intervention, determining the success and outcomes of intervention, be it medical or surgical, orbital, muscle, or eyelid itself. In the diagnosis and management of thyroid eye disease, we always talk about the four questions. First question is always, is it or is it not thyroid eye disease? Is it the active inflammatory phase of the disease where all these immunomodulating agents may be of role versus inactive disease where we are already conservatively managing them or doing rehabilitative work? Is it in terms of severity of the disease, mild, moderate to severe, or sight-threatening disease? And the UGOGO 2021 protocol rightly acknowledges the role of quality of assessment even in patients with mild disease. And you can see it in this particular flow path where we talk about even in mild patients with mild disease, if the quality of life is affected, doing various forms of intervention is very important in these patients. And of course, it's well known that moderate to severe disease require more attention. Examples of patients with early active disease with proactive management with high-dose intravenous protocol treatment, we're able to make a difference not only the way they feel, but also the way they appear. A dilemma always arises in patients with compressive optic neuropathy and orthophoric eyes, where in the name of decompression, we end up using diplopia, which can cause significant disability, following which strabismus surgery is done, where we are able to restore the original form and function. Examples of patients where you have balanced decompression with good outcomes. So which quality of life tool do we really use and why? If you look at the evolution of the various quality of life questionnaires, you can classify them into the general health quality of life questionnaires, which used to be done in the past. Then there are specific disease-specific quality of life questionnaires, which are probably the most popular ones, vision-specific questionnaires, and finally the semi-structured interviews, and we'll touch a little bit of each of this as well. This is very good for systemic disease, but not very good for thyroid eye disease, and hence by default we go to the disease-specific questionnaires, where the two famous ones were the GOQOL questionnaire from the Amsterdam group and the thyroid eye disease quality of life questionnaire from the Vancouver University of British Columbia group, and a few other versions as well. These can be classified into multiple item questionnaires as the GOQOL, which is more detailed and useful in research studies, although it can be a little time consuming, or the single item questionnaires, which is a TEDQOL, which is simple, easy, fast, although it may be less specific. So the mecca of thyroid eye disease or Graves' orbitopathy studies, all came from Amsterdam. This is the very first disease-specific questionnaire, which has been translated into several languages. It has been shown to be very valid in the first questionnaire to show that an average afflicted patient with thyroid eye disease quality of life is much worse than a healthy American population, and is much worse than patients with diabetes, emphysema, and heart failure, all of which can significantly affect the patient itself. It has been the most studied and validated and been used extensively in the various clinical trials and correlates fairly well with the activity and severity of the disease. But the problem is it's a detail, and hence the completion rate is only about 78%. These are some other vision functioning and the appearance questionnaires related to the GOQOL. There was a quality of life scale study which is not used as much as was initially published, but one of the most popular ones, and is universally utilized nowadays, is the TED quality of life questionnaire by Fayers and Dolman from 2011, where it basically addresses three issues: overall quality of life, daily functioning, and the appearance on a visual analog scale, which is very easy to. And the greatest advantage is these questionnaires can be used in such a way that there's a 100% completion rate. It's a validated and reliable questionnaire and correlates fairly well with the GOQOL and also correlates well with surgical outcomes. The problem is the simplicity. Because of the ceiling effect, in patients who are already presenting with significant affection of quality of life, progression may not be well monitored in such patients. Then there's a cultural specific Singapore thyroid eye disease quality of life score, which has also been utilized quite well. It's got 10 questions along with 4 quality of life domains. While the strengths are it's culture specific and the completion rate is high, it has not been quite validated in large numbers. The fourth form of the quality of life assessment scores are the semi-structured interviews, which are very detailed, very complex, takes an elaborate amount of time, almost up to an hour, to really address the various aspects of the thyroid eye disease affecting the patient's individual quality of life, economically, physically, medically, cosmetically, so on and so forth. But actually, it's very good to address new issues, including anxiety, depression, which are very important and has been neglected in the past. So in summary, which one should you use? You basically keep in mind that in thyroid eye disease, you have to answer the 4 questions. And the fourth important question is the quality of life. Try to use disease-specific questionnaires. In a busy clinic, it is okay to use a thyroid eye disease quality of life score, which is good for screening and clinic use. Versus if you're doing a research studies protocols or doing a more elaborate assessment of patients, try to use the GOQOL. It is important that if you really want to understand the disease, then you may have to use semi-structured analysis. In my personal opinion, a consultant's time in dealing with the patient in either the first consultation or subsequently before and after medical treatments and surgical treatments are offered is very similar to a semi-structured analysis. And keeping in mind that all of the treatment that we now do for our thyroid eye disease patients is not just by a blind protocol, but a tailored and active management to these patients so that the patient's personal needs are taken care of. And these quality of life studies are also very important for healthcare resources, whether you have to lobby your own institution to provide more time, space, or care, both clinical and operating theater care, to ensure that we offer the best care for our patients. Healthcare resources allocation is very important. And you can also prove efficacy of various interventions justifying the time invested in managing these patients. In the future, we have to do a little bit more detailed analysis, and that's where the questionnaires really come in, to study specifically the anxiety, depression, self-esteem, It is even proposed that there's higher risk of suicidal ideation in these patients. Remember that passive and proactive management also have to be taken in consideration. And these patients who have chronic disease, do not ignore the long-term patients so that we are able to address their quality of life. Thank you very much for your kind attention. And I'm happy to take any questions which you can email me when possible. Thank you very much, Prasad.